Hello out there in lecture land. It's Deb Miller again. I'm going to finish up the rest of High Risk OB. We're going to talk about electronic fetal monitoring, i.e. the monitor strips. I'm going to review induction, augmentation, and tests for fetal well-being. And these are things you probably have had, but you can read these in your book as well. So let's get started. FHR, fetal heart rate monitoring, or EFM, electronic fetal monitoring, you'll see that written simultaneously, is integral to fetal surveillance. That means we're watching over the baby. Auscultation of the fetal heart rate, or the fetal heart tones, FHR, FHT, has been and continues to be a standard component of each prenatal visit. The goal of fetal evaluation with electronic fetal monitoring in late pregnancy is to determine whether the intrauterine environment continues to be supportive of the fetus. So in other words, we're monitoring to make sure that the environment inside the uterus is still conducive to this baby's well-being, okay? So let's look at contractions, okay? We've learned about contractions in the past, so we look at intensity. Are they mild? Are they moderate? Are they strong? And when you're talking about a strong contraction, that means your abdomen is very hard. It's wooden-like. You can't put your finger, indent it by any means, okay? Now, when you're palpating to determine the intensity, is the uterus, tense, firm, or hard? We want to be gentle because it's very tender. The uterus is still tender, and especially if you're having contractions. So we don't want to be, only be gentle, okay? Frequency is beginning of a contraction to the beginning of the next. These are your definitions here, if you will. Duration is from the beginning to the end of the same contraction. So frequency, how often are they coming? Every 3 to 4 minutes. Duration, how long are they lasting? Typically 60 to 70 seconds. And we want to see the fetal heart rate, fetal heart tones, about 132 to 140 with accelerations in movement, okay? So when we're monitoring, we want to see movement of the baby and good fetal heart rate reaction to that contraction, okay? So there's your definitions for contractions, okay? And typically we want to see contractions every 3 to 4 minutes lasting 60 to 70 seconds, okay? And I have a diagram that shows the increment, acme, and decrement, and I'm not going to ask you to diagram a monitor strip. It's just, that's purely review, okay? Contractions, when you see them on the monitor, they have an appearance. They kind of give you an idea of what's going on with the uterus with regards to the contractions and with how the baby's reacting, okay? So the contractions have a curve-like, if you will, and there's different shapes, and we'll talk about that, okay? We want to see relaxation in between contractions because that gives the uterus a chance to recover, okay? Constant contractions, constant stimulation is not good. It can lead to rupture and fetal distress. Nursing measures, certainly we're going to explain the procedures, any equipment such as the monitor. You're going to assess, reassure, and include the family. Okay? So here's a picture during contractions and before contractions. So as the patient contracts, there's a rise in the uterus here, okay? And again, this is just a reminder of what you have had in the past. We got the acme, that's the uppermost point, okay? And then your interval, the relaxation period, okay? So again, that's just a description, a picture, that'll help you to see it a little bit better. So we got duration, that's how long, okay? From one beginning to the end of the same, that's how long it's lasted. Frequency is in between, from the start of one contraction to the start of the next, okay? Alrighty. So let's look at the fetal heart assessment. When you hear fetal heart tones, that confirms fetal position and determines and it helps you to determine the fetal position, which will help you locate the fetal heart tone. So that sounds a little confusing, but oftentimes we gently palpate the abdomen so we can kind of feel almost body parts, but it will help you to know the best place to position your Doppler for monitoring fetal heart tones, okay? Usually it's the convex portion of the fetus that picks up, that's the closest to the wall of the uterus, and so that's where you can hear the best fetal heart tones, okay? There's presentations, and again, I'm not going to put any pictures on there for you all to determine if it's LOP or such, but breech, you can hear the fetal heart tones through the fetal back. If the presentation is vertex, you can hear through the fetal back. If it's a face presentation, it's through the thorax, okay? You use Leopold's maneuvers to help determine the position of the fetus. And again, you'll see nurses just kind of place their hands on either side of the abdomen, and they can help that helps them to determine where to place the Doppler, so you can get the best placement for your Doppler to hear the heart tones. And there's a picture. And another picture. And again, I'm not going to ask you to remember presentations and lies and such, okay? Frequency of fetal heart assessments. Well, certainly you're going to use a Doppler or a fetal heart, the little dop tone. You're going to count for 30 seconds and double. Now, if you're having a hard time counting it, or if the heart tone is a little unusual, maybe skips a bit, you want to listen for a full minute, okay? But if the patient's in early labor, we're going to listen to, at least every 30 minutes. And if they're hooked up on the monitor, that does that for you. You just have to document that you've assessed it. Active labor, maybe every 15 minutes, and certainly transitions, more frequent. And again, if the water has broken, you're going to check the heart tones frequently. Certainly, if the water breaks, you're going to immediately check the heart tones to make sure that we still have heart tones and the baby's not getting in distress, okay? You need to differentiate between the maternal pulse and the fetal heart tone. So if you're checking the fetal heart tone and you're only getting about 62 or 68, 72, but you see that you got, good activity on the monitor strip, you might be picking up the maternal pulse instead of the fetal heart rate. Okay? Now, normal fetal heart rate is 110 to 160, and some books will say 120 to 160, but typically 110 to 160. Tachycardia, that's when the heart rate's fast, right? Anywhere from 161 up to greater than 180. Bradycardia, anywhere from 100 up to 110, or it could be even, they categorize it mild, moderate, or severe. A moderate bradycardia may be 80 to 100, and severe may be less than 80. Again, if you have a patient on the monitor and you're picking up low heart rates, you got to look and see what the contractions are doing, because the baby is responding to the contractions, and so perhaps that environment is not conducive to the baby's well-being, and they may have to deliver, okay? You have an external monitor that monitors your contractions, and it monitors contractions and it monitors fetal heart rate. There's advantages and disadvantages, and certainly the advantages, it doesn't depend on dilation or descent, so you can put the monitor on them with ease. It's certainly not as reliable as an internal monitor, but it's certainly more comfortable. A disadvantage is the quality of tracings may not be as accurate, if you will, as an internal, and certainly you can't measure the intensity of the contraction using an external monitor, okay? Certainly, with nursing measures, you're going to reassure if we need to adjust the straps. Sometimes with a position change, you have to readjust the straps, or if the baby starts moving, you may have to move that Doppler around a little bit, okay? And I think everybody has been to labor and delivery, so you probably have seen the straps. You've seen them hooked up to the monitor, so I've got a couple of pictures on some slides, but basically you have two straps, and one Doppler or transducer picks up the contractions, and the Doppler picks up the fetal heart rate, and you typically use a little gel on the sensor that picks up the heart rate, okay? So again, you've all probably seen the straps, and there's pictures in your book that you can look at as well, okay? Let's see. There it is. You got 2 straps. This right here is picking up the fetal heart rate, and this is monitoring the contractions because it's at the fundus, the top of the uterus. Okay. Alrighty. And now in this picture, that's the Doppler that's placed near the fetal heart. That's what you're going to use the gel on. So that's picking up the fetal heart rate. You can see the outline of the baby. Okay. And then this is the toco transducer. That's put at the uterine fundus, as I said. This picks up the contractions. That picks up the contractions, so they put it at the top of the uterus to be able to pick up the contractions, okay? Here we go. The Doppler toco transducer picks up contractions. The Doppler picks up fetal heart tones, okay? This is a picture of internal monitoring. And again, the physician or the nurse midwife places this. And sometimes they, also include a fetal scalp electrode, okay? You have to have special training in order to insert these, okay? And then there's a fetal scalp electrode. You can see it's put right into the fetal scalp, and here's your intrauterine pressure catheter, okay? Internal monitor. Okay. So let's talk a little bit about some advantages and disadvantages and requirements for use. So advantages would be increased reliability of tracings, okay, so a little more reliable tracings. It limits the mom's movements, however, and they're at risk for possible infection. Sometimes the fetal scalp electrode can be misplaced, okay. But one of the greatest advantages, though, is more reliable tracings, and so you get a better snapshot of the contractions and such. Requirements for use: their water has to be broken, so got ruptured membranes, and got to be at least 3 centimeters dilated. Certainly, the mechanism of action for an intrauterine pressure catheter, it's IUPC, is passed through the vagina, cervix, and into the uterine cavity alongside the fetus. It evaluates frequency, duration, baseline strength and peak, other known as intensity, of the contractions. It evaluates if the uterine tone decreases to baselines between contractions, so it'll tell you whether or not we've got that resting phase in between contractions, okay? Baseline, and again, I'm not going to expect you to memorize these, but anytime you insert a monitor, you're going to get a baseline reading so that you can determine if we're getting hypertonia, meaning the uterus is overstimulated, okay? Which would compromise the maternal and fetal well-being. Okay. Fetal scalp electrode, the head's engaged. In order for this to be placed, the electrode is passed through the vagina and the cervix and attached to the fetal scalp. Sometimes, if they're breached, it may end up in the buttock, but that's certainly not the goal. And what happens is the mechanism, if you will, is that an EKG is obtained and it's fed into the monitor onto the graph paper, okay? So you can really monitor the fetus closer too. Telemetry can be used to monitor contractions and fetal heart rate through an IUPC and fetal scalp electrode with small radio transmitter in the vagina that transmits to a distant monitor. It's costly, but client's able to ambulate. So we don't typically see this, and I've never seen someone in labor monitored like this. However, I think in some of the literature it states it can be, but I've not seen it here, okay? Fetal heart rate patterns. Let's look at assessing and interpreting these patterns. Now, your book does a very fine job of showing you pictures of accelerations and decelerations, and again, we're just going to go over these, not spend a long time with them, because when you're interpreting fetal monitors, that is a skill that has to be cultivated. It takes time and it takes practice. So I'm basically concerned with us knowing the more common strips, and I'll point those out as we go along, okay? Okay. certainly you're going to establish a baseline fetal heart rate. So you're going to record for 10 minutes times 2 episodes. Fetal heart rates in between contractions. Okay, so we're going to hook them up to the monitor. We're going to run a strip for at least 10 minutes. And certainly, if they're having contractions, we want to go through at least, several contractions so that we can get an idea of what the heart rate is in a resting state, so in between contractions, okay? Normal rate is 110 to 160 with some normal fluctuations. Now, when the baby moves around or there's a contraction, we're going to expect a response, and that response is going to be manifested in the fetal heart rate, okay? So let's look at some abnormal fetal heart patterns. Bradycardia, and this is all on your slide here, so you don't have to write a whole bunch down, okay? Just listen. By definition, it's a heart rate less than 110. Mild bradycardia is 100 to 110, moderate is 80 to 100, and severe is less than 80. Now, if you got a baby whose heart rate's going, less than 100 and staying there, you've got a baby in distress, okay? Causes mild to moderate, usually not serious, and is maybe related to vagal stimulation due to head compression, okay? Severe bradycardia, however, is probably due to hypoxia and is very dangerous if it persists for more than 2 to 3 minutes, because then you got brain damage. Nursing care, certainly. Change position, the maternal position. You might administer O2, and if they're on PIT, you're going to turn it off. You're going to notify the doctor as well as the pediatrician for treatment. A heart rate that's too low or a heart rate that's too high is cause for concern. This baby is is in distress, okay? Let's look at tachycardia. By definition, it's greater than 160 per minute times 10 minutes, so that's prolonged, so we don't want to let this continue on, okay? So mild by definition is 161 up to 180, severe is greater than 180, and causes typically are fetal hypoxia, maternal fever, drugs, fetal anemia, fetal arrhythmias, maternal dehydration, maternal anemia, and maternal hypothyroidism. Now, let me just say this. If the mama's running a fever, chances are the baby is. And we couldn't check the baby's temperature, but we can know this by their elevated heart rate. That's a response to the mom's fever. So if you have a patient who is running a fever, you would anticipate that the fetal heart rate would be high. So if you saw an elevated fetal heart rate for no reason, contractions are going good, perhaps the mother has a fever, or maybe there's history of drug use or something along those lines. And so think in terms of when you see something, if the baby is doing something different on the monitor, like the heart rate's going up or going down, check your mom as well, okay? Certainly, care and intervention is going to be change their position, administer their oxygen, turn off the pit because we don't want to continue to overstimulate the uterus and keep this baby in distress. And certainly notify the physician, okay? Notify the physician. Variability. Baseline variability is a reassuring fetal heart rate pattern, okay? So you want to see some variability. It's the differing rhythm in the fetal heart rate over time. It's like that jittery line. There's increases with fetal stimulation and decreases with fetal rest. It's like that push-pull effect. So you want to see some jittery lines, some up and downs, because that's the difference. There's a variation in the heart rate and from the baseline. So baseline variability is a reassuring fetal heart rate pattern. Okay, so when you see that variation, and it returns back to the baseline, that that's good. And I'm going to show you in class some examples of that, and we have some slides on here as well. Certainly, absence of variability, fetal natural pacemaker activity has been affected. Causes. Could be narcotics used in labor, but could be due to fetal hypoxia or acidosis. You must intervene. So if you have a flat line or very little variation, that's cause for concern. You have a baby in distress. Premature babies, however, they're going to have decreased variability because their nervous systems have not developed fully, so they may not have a lot of variability. And so if you know you're monitoring, this is a premature baby, then you know that you're not going to have a lot of variation there, okay? Short-term measures R wave to R wave. Beat to beat is the difference between successive beats, approximately 3 to 5 beats per minute. Subtle changes can be picked up with internal monitoring, okay? So you want to see some beat-to-beat variability, okay? It's changes in the fetal heart rate from one beat to the next. That's all that means, okay? It's either present, and that's what you need it to be, or it's decreased. And if it's decreasing, for instance, like you have very little bit of difference in between, or it's a long time in between changes, you probably got a fetus in distress. And if there's no beat-to-beat variability, then we've got a baby in distress, okay? Causes of abnormal variability would be fetal tachycardia. Again, prematurity. If the baby has anomalies, maybe fetal heart anomalies or anomalies within the central nervous system, that would cause some abnormal variability. Sometimes when the baby's asleep, fetal sleep, you don't see a lot of that variation. So, you tend to try to, wake them up, stimulate a little bit, see if you can't get that to change. If you can't, you don't let this go on because you got a baby in distress. You notify the doctor to evaluate, okay? Long-term variability, that's the larger rhythmic fluctuations over 3 to 10 cycles per minute. So you're going to see variations normally from 6 to 10 beats per minute. I'm not going to ask you to necessarily memorize these numbers. However, I want you to know that you will see a variation, a variation in your variability from the baseline. If you don't see any variations, like you don't see the sudden increase and decrease and maybe staying up a little bit and heart rate elevate a little bit and then back to the baseline, you may be seeing a baby in distress, okay? Some sinusoidal patterns. These are ominous and unusual, and that means the beat-to-beat variability is minimal or even absent, okay? And it may be because there's no fetal movement, and it may be due to fetal asphyxia, fetal anemia. You got a baby in distress, okay? If on the external monitor, they'll need internal monitor, and if the pattern is confirmed, they'll need a C-section, okay? Again, when you have some ominous patterns where you don't have a lot of fluctuations, if you will, within your heart rate, you may have a baby in trouble, okay? And non-periodic changes is simply just that. Let me get to my notes. It refers to fetal movement or changes in position. It's not associated with contractions, okay? So nursing care, you're going to continue to monitor. Okay, here's some non-periodic accelerations. You can see some accelerations in the fetal heart rate, some accelerations, and they're not significant or associated necessarily with the contractions, okay? These are contractions down here, fetal heart rate up here. Okay, some periodic accelerations. Okay, some periodic accelerations, okay? It's in response to fetal movement or uterine contractions. Also may have some deceleration, so, in addition to the periodic accelerations, you may have some decels also. Hopefully, though, the baby's able to compensate as far as their heart rate goes. Cord compression with contractions sometimes occludes the umbilical vein and decreases blood flow, which increases fetal heart rate to compensate. So when you've got some compression there, the fetal heart has to compensate, so the heart rate will increase. Significance, well, it can mean maybe a decrease in amniotic fluid or cord compression. Change position and continue to monitor, okay? Continue to monitor. And you're going to learn in a little bit when we talk about decels, late decelerations, early decelerations. You know, you do what's easiest first, and that's change the position. Here's some periodic accelerations. Here's your contraction, and here's the elevated fetal heart rate. There we go. No, looks like some early. Okay. Decels. Early are typically U-shaped that mirrors a contraction, usually benign and reflect the compression of the fetal head as it enters the birth canal. Okay, so early is usually due to head compression. I want you all to write down veal chop. V as in victory, E-A-L. Okay, and then beside it, you're going to write the word chop. C-H-O-P. And this is regarding decelerations, and this is the easiest way to remember these. So the V stands for variable contractions, and that's due to cord compression. Okay? So V equals C, variable due to cord compression. Early decels are usually associated with head compression, so E equals H. Accelerations are okay. We want to see the heart rate accelerate from the baseline. L stands for late decels, and that's usually due to placental insufficiency. So L equals P. So you got veal chop. If you write that down and keep that in your memory banks, that'll help you to remember the causes of the decelerations, okay? Alrighty. So that's your early decels. It's usually due to pressure on the head, okay, with the contractions. So that's usually due to the contractions, all right? And there's your early, okay? We got a deceleration, and it's, whoops, let me go back. Okay, we got it. The heart rate's decelerating right here, and it mirrors the contraction. Can you see that? That's the contraction, and it's a mirror image. Then we have some rest in between contractions. The heart rate comes back to the baseline. Then we have another deceleration. There's your contraction, okay? And then we go back to our baseline, so we're recovering. As the uterus is resting, the fetus is resting. They go back to their state. Okay, so now you're probably thinking, wow, that was dropped down a little bit. So we're going to continue to monitor, but we're probably not going to let that go on for very long, okay? Late decelerations, that's usually due to placental issues, okay? It's usually due to placental issues. When the utero-placental reserve is adequate, fetuses normally tolerate transient stress of repetitive contractions, but with ureteral placental blood flow, fetal hypoxia can take place, especially, and which leads to late decels, okay? Late decelerations usually occur in normal fetal heart rate range, but may be subtle or they could be obvious. You got to check your variability, okay? Causes of late decels is usually due to maternal hypotension or hypertension, diabetes, but in all of those conditions lead to placental insufficiencies. So you got a problem. It's due to the placental insufficiencies, okay? So late decels require prompt intervention, okay? The base variability is of utmost importance. The object of intervention with a late decel is to maintain oxygenation while assessing and eliminating the stressors. Nursing care. Change position, elevate the bed, head of the bed, give them O2, increase their fluids, stop the pit until the fetal heart rates return to normal, and then only if your doctor tells you to, okay? So the main thing is you do what's easiest first, change their position, and while you're changing their position, you're going to raise the bed and give them oxygen, all right? So let's look at some late decels. Okay, the contraction is starting to end, and it's starting to relax. Can you see the late deceleration? So the heart rate is decelerating late. That's after the contraction starts to resolve itself. Here, this one is a little bit better even. And see, it's not too far. The deceleration is not too far off the baseline, okay? So it's decelerating while the contraction is relaxing, okay? I can tell you on the test, you'll have an early decel, a late decel, and probably some variabilities. They'll be very. I want you to know what the normal abnormal ones look like. In other words, I want you to know what it looks like. I'm not going to put anything rather tricky or anything for you, but if you have these images in your mind and what they look like, you'll do just fine, okay? So prolonged decelerations, that's a decrease in the fetal heart rate greater than 2 to 3 minutes but less than 10. It's an ominous sign to indicate hypoxia has occurred. It can certainly occur suddenly, and if promptly corrected, the fetal heart rate variability will remain good. However, this is nothing that we allow to continue on. We're going to assess for the cause and correct. It may be as simple as a position change, but it depends on. We got to make sure that we don't have a prolapsed cord. We got to assess the mother to make sure she's not experiencing hypotension, or we don't make sure we don't have an abrupted placenta. Also, too, we want to monitor what medications she's receiving as well. So we don't like to see prolonged decelerations, okay? And we don't let that continue on. Another deceleration that I want you to be familiar with is variable decelerations. And remember, in veal chop, variables usually is a result of cord compression, okay? Now, variable decels tend to occur more with ruptured membranes. Their pattern is either U, V, or W shaped, okay? So nursing care certainly relieve pressure on the cord with a position change. O2, we increase the fluids. We stop the pit. Sometimes they order amnio infusion, especially if if we have a prolapsed cord or we can't get the baby's head off the cord, okay? So they'll put some fluid in, they'll, do an amnio infusion to put some fluid back in there to help get the head off the cord, okay? You have to monitor very, very carefully, though, if this is what's ordered. You got to monitor the patient's temperature, especially because, there's a risk for infection when we administer an amnio infusion, okay? So monitor their vital signs, the mom's temp. Certainly you're continuing to monitor the baby's pattern. This is a variable. This is a U shape, and this is a V shaped, and they're variable. This looks like it's probably a late. This could almost be an early, so it's a little variable. Okay. Now, if you have a patient that is experiencing a prolapsed cord, they usually put them in the knee chest. Okay. Combined decels. That's when you can have two different patterns. You treat the worst one first. Okay. So if it's a late decel, you may have to certainly change their position, stop the pit, IV, but you treat the worst one first. Okay. All in all, the best rule of thumb is, again, do what's easiest first, change their position. Okay? So you're going to evaluate the tracings. You're going to use a systematic approach. You're going to document on the strip pertinent information such as position change, bedpan, membrane status, their vital signs, if you gave any medications. Those are some of the things you're going to put on the strip, okay? And you're going to continue to monitor. Nursing care and intervention certainly is monitoring. And if you're not certain of what this strip may look like, you go and get someone else to help you with it, okay? So you can always get a second opinion, okay? Responsibilities during labor, certainly you're going to monitor the mother's vital signs. You're going to maintain hydration and nutrition and elimination, which may involve certainly your IV fluids, intake and output. They don't give them full meals. Now, some folks do stop at the drive-thru before they come in for delivery, but they don't give them full meals, and because in the event that we should have a fetus in distress. They may have to go for an emergency C-section, so you don't want a full stomach. And then elimination, depending on the facility. Some facilities, once they put in an epidural, they put in a catheter, and some do not. And it may be a physician preference or a patient preference. So, but you still have to monitor their elimination. Make sure they're emptying their bladder. Fetal assessment, you're going to obtain a baseline fetal heart rate. You're going to monitor for variability, for accelerations, and any kind of periodic changes with regards to decelerations, okay? And we talked about veal chop. Make sure you have that in your notes because you will see that again, okay? Interventions for non-reassuring fetal heart rate pattern. Well, let's say that we've got some late decels and or the pattern's looking very ominous. You're going to do what's easiest first. Change their position, give them oxygen, increase their fluids, boost their fluids up, stop the pit. We don't want to continue to stimulate the uterus. You'll do a vag exam to rule out a cord prolapse, because if we've got a prolapse cord, we've got to flip them up, get them in a knee chest. You notify their primary caregiver. Anticipate administration of terbutaline if indeed they're before 36 weeks or 37 weeks. You may anticipate starting an amnio infusion if indeed we got cord compression. We got to float the head off the cord so we can get some circulation there. And you document. That's illegal. That's part of the legal record. And in cases of lawsuits involving OB patients and such, they're going to look at the monitor strips. They're going to look at the record in labor and delivery, especially if you get a baby that has been fine throughout the pregnancy and then they're delivered with problems. They're going to look at your strips. So always document what's going on, okay? Let's look at assessment of fetal well-being, third trimester, indications for testing, which would include maternal conditions. If you have a mother who is hypertensive, we're going to determine fetal well-being, because remember, we want to make sure this is part of fetal surveillance. We want to make sure the environment that the fetus is in is still safe enough for that baby to survive, okay? Or would that baby be better outside that environment? In other words, is it better for the baby to be born than to stay in that environment, especially if the mom's got high blood pressure or diabetes, have chronic renal disease, perhaps they have cardiac conditions? So we will implement or use tests for fetal well-being to determine, is it better for the baby to be in or out, okay? Some prenatal conditions, certainly PIH, we're going to determine fetal well-being. If a mother presents to the clinic or the hospital and says, my baby hasn't moved in quite some time, we want to monitor for fetal well-being. And, it may be as simple as doing, fetal movement checks. However, we want to put them on a monitor and make sure they're okay. Let's see, fetal movement assessment. Certainly we want, third trimester, we expect lots of movement. At least 720, around about 700 for a whole day, but at least about 30 movements per hour. That varies between person, and certainly when you get closer to term, that head engages, you might not have as much movement, but you still expect some movement. If you have a patient who's gone for several hours and certainly even into 24 with no movement, that's cause for concern. Baby could be in distress, okay? So if you ever have a patient that says, I'm not feeling my baby move, have them to monitor. Maybe the baby's asleep, have you eaten today? Kind of stimulate and see if you can get the baby to move, okay? Non-stress tests, fetal heart monitor, we'll hook them up and see if the baby's looking good on the monitor. And we have to keep in mind fetal age. If the baby's premature or not quite to 32 weeks, they may not have as much movement, okay? And maybe their heart rate is fluctuating erratically. So, again, to assess for fetal well-being, we're going to put them on a monitor and or do a non-stress test to make certain that the baby is better inside as opposed to outside and vice versa. Okay? Conditions that warrant a non-stress test. They're usually useful in clients with diabetes, PIH, or intrauterine growth restriction, spontaneous rupture of membranes, patients that are post-dates. These conditions can lead to decreased uteral placental function, which means decreased oxygen to the fetus, which equals asphyxia. Okay. Other indications for non-stress test: if the patient has a history of a stillbirth, chronic renal disease, decreased fetal movement, like they haven't felt the baby move, they're going to do a non-stress test. If the mom is has sickle cell, or is anemic, they're going to probably schedule a non-stress test. It's usually scheduled in the daytime, either in the office or the hospital. It's non-fasting, but you ask the patient not to smoke, which they don't need to be smoking if they're pregnant anyway. They're put in semi-Fowler's position with a small pillow behind the right hip to displace the uterus to the left, and they're hooked up to the monitor, and they're asked to, punch a button every time they feel the baby move. A non-reactive usually is spontaneous decels. They're brief. They're non-repetitive. They're probably benign. However, we're still going to continue to monitor them. Okay? We're going to continue to monitor. So let's look at this. She's on an external monitor for a non-stress test. And every time she feels the baby moving. So we got good acceleration from our baseline. Okay? Here's a reactive. We've got good acceleration, good fetal movement. Okay? There's a non-reactive. You don't see a lot of fluctuations. See, she feels that baby moving there, but you don't see a lot of acceleration, okay? You don't see a lot. Let's see. Let me give you some numbers there. Let me go back. Yep, here we go. A reactive. This is very important, okay? So you got two accelerations of at least 15 beats per minute, lasting at least 15 seconds in a 20-minute period. So you want to see two good accelerations of at least 15 beats above their baseline, okay? We want it to last at least 15 seconds in a 20-minute period. So a normal reactive non-stress test wouldn't take much more than 30 minutes. Non-reactive, there's lack of sufficient increased fetal heart rate over 40 minutes, okay? So reactive, we want to see two good accelerations. Here's two. We got three good accelerations. See, here's your baseline, so that's gone up. Okay, so that's good. Here's a non-reactive. We don't see any very much acceleration, okay? And certainly not for it's not accelerated for at least 15 seconds. So this is non-reactive, okay? We want to see reactive. That's reactive is good. That means the baby's doing well, heart rate's accelerating in a normal manner, and that's what we expect. Additional test, a contraction stress test, and that's the fetal's response to contractions. You have fetal movement counting. You have the biophysical profile. Okay. Vibroacoustic stimulations. I'm going to just let you read that in your book. You don't see that. It's not used very often, and I'll be honest, I've not seen that used around here. Contraction stress test, that's the contraction stimulation test. It identifies fetuses at risk due to intrauterine asphyxia. Okay. Oops. Wow. Okay. So, there you go with that one. Now, here we go. Contraindications. Contraindications for a CST: third trimester bleeding or unexplained vaginal bleeding, if there were a previous C-section with a classical incision, and if at risk of preterm labor outweighs the advantage of the CST, as with patients with premature rupture of membranes. So you don't want to you don't want to stimulate their uterus to where they're having contractions if they're not, certainly if they're at risk for premature labor, because you don't want them to go into labor prematurely, okay? Nursing care, explain the procedure or reason for the test, the equipment, the normal variations, consent form is necessary. You put the patient in semi-filers, usually a side-lying position, external monitors for the contractions and the fetal heart rate. Usually you obtain a baseline. It takes maybe 15 to 20 minutes, and you check for fetal activity and the variations and the response to contractions, okay? Now, this can either be accomplished through nipple stimulation, because that will stimulate the uterus to contract, or it can be used with administering a very small amount of Pitocin to elicit a contraction, okay? Interpretation. If you have a negative OCT or CST, it's the absence of late or significant variable D cells. A positive means there's presence of late D cells following 50% or more of contractions, even if the contraction frequency is less than 3 per 10 minutes. So, to keep this straight, you want a reactive NST, but you want a negative OCT or CST, okay? So, I'm going to ask you to know the difference between them, okay? Okay, clinical management. Desire a CST that's negative with a reactive NST. That's desirable. Recheck in 1 week. A negative CST and a non-reactive NST is more difficult. You're going to have to assess carefully for subtle late D cells, and if none, repeat CST in 1 week. Okay? And all equivocal tests, if you're unable to determine, you're going to repeat in 24 hours. A positive CST and a non-reactive NST means the fetus cannot withstand labor, and if they're equal to or greater than 32 weeks, they'll probably go ahead and do a C-section. Again, we're checking for fetal well-being, and that's because perhaps this patient has some sort of condition, either a chronic condition like diabetes or hypertension, or they've developed PIH. So we're determining whether or not that baby can survive outside or is better off delivered as opposed to staying in utero, okay? So we want a reactive non-stress test but a negative CST, okay? Here's a negative. And here's your contractions, and we've got good acceleration, so that looks pretty good for 10 minutes. Here's a positive. We got some late D cells. Although they're early, they're still late D cells, and so we might repeat this test. Okay? I'm going to just let you read this biophysical profile. You can read this in your book as well, but I did put that on there because some facilities will use this to determine fetal well-being, and the indications are the same as a non-stress test or CST. Okay? It's helping us to identify whether the baby's compromised or if they're healthy. Okay? Alrighty. So, most important indicators. A non-stress test reflects intactness of a CNS, the central nervous system. Okay. The amniotic fluid index reflects fetal renal perfusion. So, if we have an adequate amount of amniotic fluid, that means the fetus's kidneys are working. They're working good. Measure deepest pocket of fluid, each quad of maternal abdomen, and then sum to calculate the amniotic fluid index. Again, that's another means of fetal well-being, and again, it would probably determine what's going on with the mom and what they anticipate with the baby. But, you know, when you see adequate fluid that's not green or brown or anything, that means the kidneys are working pretty good. Okay? Part of the nurse's responsibility during fetal evaluation procedures is to ensure the client is fully informed and able to participate in the decision-making process. As a nurse, we get to we have the opportunity to educate our patients about why we're doing what we're doing and the purpose of it. Imagine even if it was your first or your fifth pregnancy, when there's changes or there's problems or potential problems, a lot of anxiety, a lot of stress begins to develop, and so it's part of our job to help alleviate and minimize their anxiety by providing adequate information and accurate information. Okay? Alrighty. So the next thing we're going to talk a little bit about is labor induction and augmentation. Induction is labor artificially started. So labor is artificially started. Augmentation is to assist spontaneous labor to be more effective. Okay? So we use the Bishop score also to evaluate for induction, and that has to do with whether the cervix is ready and the contractions and the heart rate and such. And there's a table in your book. I'm going to refer you to that. Nursing considerations, certainly if you're inducing labor or augmenting labor. You're going to monitor vital signs, intake and output. You're going to monitor for hyperstimulation. If you're using Pitocin, certainly you will be. You don't want to overstimulate the uterus because that can lead to rupture and distress. Okay? Monitor the fetal heart rate for decelerations. Reasons for induction. Certainly if you have a fetus in danger or labor does not start spontaneously at term. Also, if the patient has PIH or some renal disease, perhaps they have prolonged ruptured membranes and labor has not started, they'll induce the patients. Certainly all situations that increase risk for fetus to remain in utero, certain would be an indication for inducing this patient. Again, fetal surveillance. It's better to have the baby delivered than staying inside. Reason for augmentation is to make the contraction stronger if hypotonic and infrequent. So if the uterus is just not, maybe we're having some mild infrequent contractions, maybe we just need to help augment that labor by administering Pitocin. Okay? Methods to strengthen contractions: membrane stripping, cervical ripening, using either Cervidil or Cytotec. Amniotomy, where they artificially rupture the membrane. Sometimes that helps get labor started. Induction with oxytocin, Pitocin. Augmentation with oxytocin, Pitocin. Okay? Precautions. Certainly, procedure increases risk of uterine rupture, decreased fetal blood supply, and premature separation of placenta. It is used cautiously. Certainly, requirements for induction, you got to determine where the fetal lie. Are we transverse? Are we breech? Is the cervix ripe enough? Is the cervix ready to? Is it ripe enough for dilation? Is the engaged presenting part? So is the head engaged? And if it's not, then it's, you want that head engaged before you start inducing labor because you don't want a prolapse cord or further complications. And we want to make sure that there's no cephalopelvic disproportion, that the pelvic area is large enough to have the baby pass through, and is the fetus mature enough. Okay. So, and most of the time they go by dates, but now if the patient is getting into trouble, they got PIH or hypertension or renal disease, you have to weigh the benefits and the risks. So, if they're inducing and the baby is not considered term, they're going to do an LS ratio to determine if the lungs are mature enough to be delivered. And if they're borderline or not, they'll have intensive care, a neonatologist standing by and prep for admission to the neonatal ICU. So, it depends on the patient and the circumstance for which you're inducing this patient. Either it's because it's post dates or because the mom's got a problem or the baby's looking bad. Okay, so there's just those are those indications, and so we have to pay attention to what's going on with the patient. Okay. Methods to ripen the cervix: certainly stripping the membranes with a gloved finger. They'll go in and into the internal cervical os and rotate the finger a couple times to hopefully strip those membranes to help get labor started. And some of you probably have experienced that or have seen that in the office or know somebody who's had their membrane stripped. Hygroscopic agents, that's where they put in suppositories that sometimes, most of them are made out of seaweed that swell on contact with cervical secretions, which helps encourage or urge the dilation process, okay? Sometimes they use prostaglandin administrations that helps to soften and efface the cervix. And then, again, the Bishop score has got to be equal to or greater than 8, which would indicate a ripe cervix, okay? And you can review that table in your book, okay? So what's the risk here? Well, certainly uterine hyperstimulation, non-reassuring fetal status, increased risk of postpartum hemorrhage. Contraindications is the same as with induction, okay? We got to be real careful. We're going to monitor the patient, monitor the fetal heart rate, and look at the uterine monitoring, make certain that we're not hyperstimulating, in other words, greater than 5 contractions in 10 minutes. Put them on their side and administer oxygen and assess for fetal distress. That's very important, okay? Caution use in women with heart and hepatic and renal disease. When you're talking about using hygroscopic agents or prostaglandins, you got to be real careful. So you have to have a thorough history before you start administering different cervical ripening agents, if you will. Here's an amnio hook that's used to break the water, artificially rupture the membranes. Amniotomy is the biggest risk is a prolapsed cord. So if the head's not engaged, there's a risk for prolapsed cord. Okay. Other risk would include abruptio placenta and infection, or even an amniotic fluid embolism. Okay. Nursing care: check the heart rate immediately before and after rupture of membranes. You want to note the amount, the color, the odor, whether there's any staining, blood, and the consistency of the fluid. Change the patient's position frequently because they get wet, and you got to check their temperature at least every 2 hours, okay? Simply because the water's broken, they're at risk for infection. Every time you go in and check, they're at risk for infection. Reassure there's no dry birth because amniotic fluid produces continuously. So, patient, however, must deliver within 24 hours, related to the increased risk of infection. Okay? Now, your book has a box that has the information on Pitocin, oxytocin, and let me check this page number. Now, I'm using the 5th edition. It's the yellow book, and I think most of you have that book. And if you have a different book, I want you to look up oxytocin or Pitocin, and I want you to write that in your notes because you're going to need to know about oxytocin and Pitocin. In the 5th edition of Littleton, it's the yellow book, on page 467, there's a lavender box, and it is your information on Pitocin. And I want you to put a star by that because you're going to need to know this box. You need to know certainly indications for use and any side effects and nursing considerations, okay? So put that in your notes and make sure that you know the nursing considerations, okay? Certainly, side effects of Pitocin is peripheral vessel dilation, which leads to hypotension, excessive stimulation of the uterus, which leads to tonic uterine contractions, which can cause placental abruption, uterine rupture, and fetal death. Water intoxication. oxytocin is an antidiuretic, so you have to be very careful. You have to monitor them carefully. Initial signs and symptoms are headache and vomiting. You want to stop the pit and report it. Secondary signs and symptoms include hypotension, tachycardia, dizziness, seizures, and certainly can even lead to death related to the tissue fluid shift. So you've got to really be careful and monitor them closely. Rapid labor, there's a chance of increased painful labor with Pitocin. It decreases the time of the first stage, so the length of the first stage of labor is diminished considerably, and it can be a very, very fast labor, which would then lead to a possible postpartum hemorrhage, certainly lacerations, uterine hypoperfusion, so baby's not getting well perfused, which can lead to fetal distress and other problems. If the uterus is hyperstimulated, that decreases the oxygen to the fetus, okay, which could lead to possible trauma from a rapid birth. So if we've got a rapid labor and a rapid birth, that leads to rapid trauma for the baby, okay. Nursing measures, and again, when you're administering Pitocin, there's standing orders for this, and so you follow those orders, and of course they're individualized based on the patient, but there's certain standards that we utilize, such as vital signs every 15 minutes. You're going to monitor the contraction pattern, and with each dose increase, so as you titrate that and increase or decrease your pit, you're going to make certain that you monitor your patient and document their vital signs and the fetal heart rate, what the contractions are doing. Contractions should not be less than every 2 minutes, but certainly not stronger than 50 millimeters of mercury pressure. They should not last longer than 70 seconds, okay? They should not last longer than 70 seconds. If they do, DC your pit, give them a little O2. Sometimes I might administer a little bit of breathing to decrease the uterine activity. Perform a vag exam with changes in frequency and intensity of contractions. If your contractions are changing, they're getting more frequent or more intense, you want to do a vag exam to make certain everything is okay, make sure that we're still dilating, and make sure we don't have a prolapse. Accurate intake and output. You limit the total amount of infused. Pit is piggybacked. It's not the primary line, and that makes sense because if you have that as your primary line, if you have to cut it off, then they have no fluids going. So you have a primary line, and pit is always piggybacked in. You monitor for water intoxication, fluid overload. Reassure, use pain relief measures. Monitor fetal heart rate. One thing I've not mentioned or talked about is certainly, focused breathing, childbirth experience, and childbirth classes. And if not everybody goes to childbirth classes, and so they may not learn how to breathe through the contractions and how to focus and such. And as a nurse, that's part of what we'll get to do, help them to breathe and relax in between the contractions and not tense up. So, in addition to pain relief measures, that would be your breathing exercises and your relaxation techniques and such. That would help with the pain relief in between contractions, okay? And oxytocin is given after the placenta is delivered, and it's to maintain the tone and prevent postpartum hemorrhage, okay? So it says check your hospital policy, but a frequent protocol is to add 20 units of pit to 1,000 milliliters of lactated ringers, okay? So, and it's infused over 40 to 60 minutes. Again, you check your hospital policy, and you follow those policies, but this is a rule of thumb, if you will. Okay, now, as I said, your book's got some great tables, and I want you to be sure you review your chapters and look at your notes. The chapters that cover this content is chapters 11 through 14 in your maternity book, okay? So 11 through 14, and again, I'm going to review some of this information in class and kind of give an overview of this content. So thank you very much, and I appreciate your patience in listening, and I look forward to seeing you in class. Thank you very much. Bye.